Good afternoon. My name is Craig Spencer. I am an associate professor of public health and emergency medicine here at Brown University School of Public Health and at the Alpert Medical School. Also an inaugural faculty fellow here at Watson, true interdisciplinary. Thanks for joining us on the Pandemic Anniversary Panel. Today's event is called The Next Global Pandemic, How Ready Are We? And today we'll be assessing the last 5 years and asking what lessons have we learned, what have we done, and how should we continue preparing for the next pandemic? I want to take us back to 5 years ago. Maybe you don't want to go back there. It was just about 5 years ago that the NBA canceled the upcoming season or the rest of the season, which despite all of my efforts to convince my parents that I knew something about what was happening, that was the one moment that I think they and a lot of other Americans took COVID seriously. And it was about a week or two after that I would walk into the hospital in New York City where I worked as an emergency doctor. And I've said this dozens of times, but it felt like walking into the apocalypse. Crossing over the line into the ambulance bay in the hospital, into the emergency room, and seeing dozens and dozens of people all unable to talk because they were all on ventilators. The only sound that you heard was the sound of beeping machines giving either oxygen or medications. And then spending the rest of that shift trying to find a way to take oxygen tubing from outlets on the wall, bring them up into the ceiling so that we could drop them down into the middle of the emergency room so that the people who weren't being ventilated had access to ongoing oxygen, because what was happening, there was not enough nurses, not enough staff to make sure the tanks under their bed were filled, and people were suffocating as those ran out. It was just about a week or two after that one of my friends died by suicide, who was running the hospital where I had worked. And I think for folks like myself that were inside of hospitals, the last 5 years, I think, are a bit of a different memory. Now, I think we look back over these past 5 years, and we don't talk as much about that. We talk about school closures and mask mandates. Talk about vaccines, whether we can trust them or not. But I want to remind us that first, those initial days and the horizon was dominated by fear and uncertainty. Where are we today? The COVID contrarians, many who over the last 5 years gained notoriety not because of their great ideas, but because they were willing to say them louder than everybody else, have rise to positions of the utmost authority here in the US. Just today, Jay Bhattacharya testified as part of his hearing to run the NIH, repeating many of the same things he's repeated over the last 5 years. You have RFK Jr., who is telling us that maybe fish oils is the response we need to a measles outbreak in Texas. And we have the active dismantling of the global health infrastructure that has been built up over a very long period of time that we have used to respond to disease outbreaks all around the world. In outbreaks and pandemics and epidemics, there is often a cycle of action that transitions into apathy and subsequently amnesia. We find ourselves at a moment when very few Americans talk about COVID in their daily lives, despite the fact that COVID continues to impact nearly everything in our daily lives. So I'm grateful that at least here today at this moment, we're making room for discussion to talk about what brought us to this moment and where we go next with respect to pandemic threats. And with that, I will pass it over to our moderator today, Jennifer Nuzzo, the director of the Pandemic Center and a professor of epidemiology, to begin today's conversation. Thank you.
Great, thank you. Thank you, Craig, for that sobering introduction, and also really for all the work you did for the last 5 years. And before that, I know you were on the front lines, literally putting your life on the line, and very grateful to you for your leadership, but also your bravery. So we're here because it's been 5 years. It's been 5 years since the start of COVID. And by now, the tolls of this incredibly profound event, the health tolls, I think are quite clear. We know that millions of lives have been lost across the globe. sometimes I think important to reflect on that because we see them often as numbers, but really these are individual human beings, loved ones who are no longer with us as a result of this virus and the disruption that this virus caused. I remember at the early stages of the pandemic, a friend asking me, actually I didn't remember it, but the friend reminded me recently that he had asked me, how many Americans do you think could die from this virus? Do you think we could lose 1 million Americans? And apparently I said, yes, I do think that we could lose 1 million Americans. And sadly, that turned out to be the case. We lost more than 1 million American lives from the direct tolls of this virus. We know that collectively, these tolls have resulted in historic decline in life expectancy globally. And those are just the health tolls. I mean, the social disruption, the political disruption, perhaps the political moment that we're in, the economic tolls and changes, really many profound impacts, some of which we are still trying to untangle. That is quite clear. But as bleak as that is, I think there were also some moments of success and some innovations, positive innovations that this crisis really helped develop. Clearly, the development within a year of multiple safe and effective vaccines was really a historic humanitarian achievement. And despite the contrarians and despite the debates that we're having now, even including legislation being introduced to make it a crime to administer said vaccines, I think it is really important for us to affirm the truly extraordinary achievement that was. But not just vaccines. We have whole new types of surveillance approaches, right? We can now, in the privacy of our own home, test ourselves for not just a single viral pathogen, but multiple viral pathogens, and use that information to decide if it's safe to go see our, elderly loved ones, or if we should stay home. We have wastewater surveillance. It was a totally new approach that was set up because we were scrambling to track COVID, despite the fact that our access to healthcare was suboptimal and that there are biases in our public health data sets. But now this is a kind of a flexible platform that we can use to track multiple pathogen threats. It's one of the best ways that we have right now to understand this H5N1 virus and where it is. So I think we have to also reflect on the positive outcomes. But despite these, I think, important successes, I think no one would agree that we're where we need to be going forward. And despite the fact that it's been 5 years since COVID, the list of, pathogens that we are worried about has not gotten smaller. In fact, it has only grown. Now there's multiple disease emergencies happening here in the United States and across the globe that we are acutely worried about, that we are struggling with. And I think that in light of those struggles, we have to say, what do we need to do? What can we learn from COVID? What is still left for us to do? The list is a lot, but I hope by the end of this conversation, we'll have, sort of the prioritized list of areas that we can look to. So to help us have this conversation, we are joined by 4 extraordinary panelists. I believe there are pamphlets somewhere around here with their full bios, so I won't read their full bios, but just to introduce them by name. Sitting next to me is Dr. Scott Rivkees, who's Associate Dean for Education in the School of Public Health and Professor of the Practice of Health Services Policy and Practice. Sitting next to Scott is Dr. Adam Levine, Associate Dean and Director of the Center for Global Health Equity in the Division of Biology and Medicine, and Professor of Emergency Medicine and International and Public Affairs. And next to Adam is Dr. Larry Warner, who's Chief Impact Equity Officer at the United Way of Rhode Island, President of Rhode Island Public Health Association, and Adjunct Assistant Professor of Health Services Policy and Practice here at Brown. And last but not least, at the end of the line here, is Dr. Teresa Raimondo, who is Assistant Professor of Engineering. And we're going to dive into this conversation. So maybe just to open up, because of the amnesia that Craig spoke about, maybe just to have you just kind of offer your reflections on where you were 5 years ago. What were you doing? You can react to that question in your professional recollections, but you can also speak to kind of your personal recollections of where you were, however you want to. And maybe we'll just start with you, Scott.
Yeah, first, thanks for hosting this event. Dr. Spencer, thanks for your introduction. To the point that you made, more than 1.1 million people in this country have died from COVID, which is absolutely incredible. And even now, with vaccines, antivirals, COVID should not be a fatal disease. And people are still dying from it. So really let the memory of those who have been affected, those who will be affected, really drive us on. I was in Florida, I was state surgeon general, and I had been in my position for about 4 months. Florida is the third most populous state, probably the most medically vulnerable state, in the country on the basis of the older population. And I remember sitting at my desk right after New Year's and getting this cryptic email from CDC saying that there were 44 cases of this very serious virus in Wuhan, China, that resulted in hospitalization. And right then it clicked on me that this was something that was very serious. Within a week, we had the virus sequenced and knew it was a novel coronavirus. And then the federal response escalated after that. In Florida, we ran our response out of the Emergency Operations Center. Florida responds to emergencies very, very well. And, if you think back to those early days, first case in Florida was March 1st, 2020. First case in the US, January 21st, 2020. We didn't get vaccines up until December. And with shortages of personal protective equipment, not really understanding the biology of the virus, we were just grappling, where can we get information? And we ran a response out of the Emergency Operations Center. And just to give you a flavor of the intensity of that, the Emergency Operations Center in Florida is built to withstand a Cat 5 hurricane. Outside the Emergency Operations Center, we would have ditches, drainage ditches for when there's overflow. And people would literally leave their post stations, go out and lie in these ditches and would cry. And then they would dust themselves off and then would come back and do their job. So I would say, despite, all that's been said about the pandemic, the people who are on the front line were just absolutely incredible. People in public health, they may be paid by a state, they may be paid by the federal government, but they work for the people. And I would say, the incredible dedication that people had working in times elbow to elbow, at a time like this, before we really knew about the biology of the virus, before we had control measures, before we had enough masks, was probably one of the most remarkable things that I've experienced in my career.
Indeed, indeed. Adam.
So in March of 2020, I had 3 COVID-related jobs and 1 questionable COVID-related side hustle. So my first COVID-related job was as a frontline provider in the emergency department down the street at Rhode Island Hospital, caring for hundreds of patients with COVID, many of them critically ill, some of whom died, all while wearing the same N95 mask for 8 hours a day on shift every day because the hospital didn't have enough masks for me to use a different one each day. My second COVID-related job was I brought together a team of emergency medicine faculty and infectious disease faculty and a couple public health faculty at Brown in collaboration with the humanitarian organization Project Hope to develop a training of the trainers for COVID-19 preparedness and response for the countries in which Project Hope worked around the world. And that 8-module training, we ended up delivering virtually in multiple different languages to 4,000 frontline health leaders in about 50 countries, who then cascaded it to about 100,000 frontline providers in those 50 countries. And it was a good timing because we in the United States were, especially in the Northeast, hit early and hard by COVID. And so we learned a lot of the lessons that we could then impart to many of our colleagues around the world who weren't hit with COVID until months later in 2020. My third job was as the site PI for what would become the largest trial of convalescent plasma for early treatment of COVID-19 ever conducted. That was led out of Johns Hopkins. I was the site PI for Rhode Island Hospital and working to very, very hard to get through all of the IRB and the logistics and get a study started in record time, which we were able to get it off the ground in a month and a half. And eventually, when it was published in the New England Journal, found a 50% reduction in hospitalization with early treatment. And convalescent plasma, as a plug, I will say, is the treatment that will be available in the next pandemic early on. Nothing else will be there. My questionable side hustle was that on the day my daughter's daycare shut down, I hired her daycare provider who was about to be laid off and started a illegal daycare in my living room for my daughter and 2 or 3 other kids in her daycare. And we ran that for about 3 months. Without that sort of side hustle, I would not have been able to do my other 3 COVID-related jobs. And that was just a fact of life in March of 2020 for anybody who was working and had kids.
Larry.
So a few things come to mind thinking back 5 years ago. One was that at that time I was co-chair of the Rhode Island Commission for Health Advocacy and Equity, which is a legislatively established body tasked with monitoring the status of health disparities and making recommendations towards to promote health equity. And I had just completed an interview with Channel 12 talking about the rollout of statewide health equity measures that the Department of Health had been working on with input from different community members. And the health equity measures help us to understand where we are with community level social determinants of health. Not necessarily specifically clinical outcomes, but things like education, access to health care, community trauma, housing affordability, things like that. And one of the questions that was asked during the interview, but didn't make it onto the final broadcast, was about my thoughts on COVID-19, which hadn't yet hit locally. And in hindsight, that would have probably been the most beneficial part of the interview to air, because my fellow co-chair, Cynthia Roberts, and I, we were talking about the connection and the importance of focusing on social determinants of health if we want to promote health equity in Rhode Island. And we connected the dots in sort of a forecasting way on what we might need to think about as we learn more about how COVID-19 was going to impact communities. And the things that we talked about were pretty spot on, but just never heard. So that was, so it was interesting, and that interview's still online. So from time to time, I'll look back and like, wow, imagine what we've learned since then. I also think about being on a plane to Baltimore at the time I was in my Doctor of Public Health program, and was on my way from my preliminary oral exam, and was on JetBlue, so I had Wi-Fi connectivity, got an email at 30,000 or so feet that all university activities were suspended, effective immediately. And I said, what does this mean for my exam that's scheduled for tomorrow? So I emailed my advisor, and he said, hang tight. And about 30 minutes later, there was another email that said, except for doctoral activities. And so I said, so I went, had my exam, passed, and then within days later, they shut down everything. And then life moved on as we saw it. What we learned, and I think one of the things that society has not been very forgiving about, is that we didn't have all of the answers up front. And we learned a lot about the importance of public health communication in addition to the delivery of vaccines and clinical care. We also learned about the importance of addressing social needs and how that impacts people's vulnerability to COVID-19 and ability to connect to resources. So I don't want to jump too far ahead, but those are some of the things that come to mind during that time.
Teresa.
Yeah, so I guess I want to start by thanking those of you on the panel and everybody who was on the first lines. My father actually was a pulmonologist working in the ICU, and so I could sort of see firsthand the trauma and the effects that had on him, and so thank you all. I actually had just finished my PhD and defended my doctoral studies in 2019, and then started my PhD at MIT with Dan Anderson and Bob Langer. And the focus of my research was all about how can we engineer the immune response and how can we really engineer the immune system to prevent disease or to help to have therapeutic tissue regeneration and really cure diseases. And so we had and I was starting actually working with nucleic acid-based therapeutics, which is the platform technology that has really enabled the COVID-19 vaccines. And so I had actually just started my postdoctoral position, and the sequence for COVID-19 was released in early January 2020. And then our lab was shut down, university was shut down, and I, as a newer postdoc, was someone who said, go home. They said, maybe you can come back in the summer. And so I was very disappointed because I knew what we could do, but Moderna had it under control, right? And we knew what needed to be done. Within a few days, actually less than a week of Moderna receiving the sequence, the genetic information from COVID-19, they had designed and settled on the sequence that ultimately ended up in the vaccine. And so that was my perspective.
I'm struck by the just different natures of everyone's experiences, but some common themes there. Maybe we could just jump into the kind of discussion. And I opened with talking about some of the highlights, the positive outcomes. And I'd like to maybe start there, and I'll start with you, Teresa, on this. You said we knew what we needed to do. I fear a little bit that we have gotten a bit complacent or maybe a little spoiled in the sense that we had multiple safe and effective vaccines in a year, and perhaps for some people that's just what happens. But can you just talk to us about that achievement? Like, let's spend some time about that achievement. How hard was that? And then also, should we expect to see those kinds of successes all the time?
Yes. So I think the mRNA platform that was ultimately, one of the major, most successful platforms for COVID-19 vaccines we had a lot of background research that had already been performed and established before 2020. It was not a clinical, there was no FDA-approved RNA vaccine, and I think that did contribute to a lot of the hesitancy, particularly towards this platform. But I think what was really amazing was that this technology had already emerged as having great potential. I was looking up the timeline, and actually in 2020, in early 2020, Moderna was actually already running 9 clinical trials for mRNA-based technologies, including some that were exploring respiratory illnesses and vaccine technologies. And so we have sort of the data analytics and the computational tools already put in place to say, once we have the sequence and the genetic information to a novel, a new virus, we can go in and take that information now and know what pieces of it are going to generate sort of a protective therapeutic response when we sort of encapsulate it into these little nanoparticles of fat, these little lipid nanoparticles that allow it to be stabilized. And so I think that technology is in place. I think some of the challenges from the research perspective was, being cautious, right? This had not been tested on a large clinical scale yet. Manufacturing capabilities needed to be built up. We now know how to high throughput using fluidic technologies and continuous processing to make these. And I think what came out of it is generating, personalized vaccines. Now we can take sequences from tumor biopsies and generate protective vaccines. And so I think we have more to learn. But I think we now have much more robust understanding of the safety and how to get this through FDA approval, how to quality control these things and clinical response to patients with different backgrounds, right? With different comorbidities and how to advise.
So sort of speaking to the importance of kind of preparation and the work that went into it, and even still there were things that needed to be worked out. Really extraordinary. Before COVID-19, there was the general kind of rule of thumb that people would talk about in the field of public health preparedness and biodefense that it generally takes about 10 years to develop a new vaccine or medical countermeasures. So it really speaks to, I think, the importance of that preparation, but also that kind of political will, public will, and adequate resourcing. And then also the science worked out. Doesn't always do that.
It doesn't always do that,
Yeah.
absolutely not. So we can take just this genetic information, right? And so we don't need cell cultures. In many ways, we can design and manufacture these vaccines with a much faster turnaround than some other platforms. And so that in part enabled
Right.
us to test those quickly. And steps were not skipped. They had the animal data, they had the non-human primate. And phase 1 through 3 trials were conducted very rapidly and in parallel, but it is a vetted sort of, it went through all of the checks and
I don't want to leave the upside too quickly, but I do have to say, maybe turn to you, Larry. I think one of the early lessons that kind of very quickly we saw during COVID was that we weren't all equally affected. And that there were deep disparities, not only in who was hospitalized and who died from infection, which, lots of reasons why that could be, but also who got it. So I'm just curious, sort of in your role, like what did you see here in terms of like the disparities, and what were the approaches to thinking about how to kind of address those and to try to ensure that the response was effective, that would meet the needs of communities, and ultimately, try to increase the equity in terms of the response?
Our experience with COVID-19 was a real-time lesson in health equity, where the entire world had equal opportunity to get sick to this new virus. But yet the disease patterns followed known disparities in chronic diseases. And so that itself should beg some questions. Why were people of color, why were lower socioeconomic status communities seeing increased rates of infection and death compared to their white peers and wealthier communities? And as we saw, people who had the opportunity to transition to work from home or to isolate in place, or to have a place to isolate, or not be in an overcrowded household or community, they were better off than their peers who were in higher density communities, multiple family households, and dealing with the life circumstances that they're navigating, which is a lesson in the importance of understanding beyond, in addition to the science, and in addition to access to vaccines and access to information, and also understanding that we have varying levels of health literacy in the community, and how are we communicating efficacy and effectiveness, and what do people really need to understand in order to make informed decisions. All of that informs the disease patterns and rates that we saw and the disparities that we experienced as a community. One of the things that I'm glad that United Way 211, and particularly in our Aging and Disability Resource Center, was able to support was addressing social needs during the pandemic, and whether it was people who were food insecure, didn't have access to be socially connected because there was a health-related mandate to socially isolate, but who does that disproportionately impact or affect? If we think about the needs of older adults who are maybe already physically health challenged, and then if they're experiencing social isolation on top of that, compounds the impact of the disease and the pandemic. So a lot of multiple social factors in addition to the health factors that people were navigating and communities were navigating. The one thing I would say, as vaccines were coming online, or as mass testing came online, I think we unfortunately took a lot of the best practices of health equity, and with a sense of urgency, we forgot some of the foundational elements of thinking about our more vulnerable communities. And so we established mass testing sites, at least in Rhode Island. I can't speak to other parts of the country, but we established mass testing sites in places that were not the easiest to get to if you were relying on public transportation. Yes, the space worked out logistically, but if you had to take a RIPTA bus from Woonsocket to Kennedy Plaza to get to somewhere else in the northern part of the state or to get to the CCRI campus, that's a lot of work to get to a life-saving testing. And then when the vaccines came online, initially people were required to have an email address to register online. And one of the points of advocacy from both the United Way and the Commission for Health Advocacy and Equity is that potentially itself is creating a barrier for folks who may not have access to digital technology, whether they're because they're an older adult or a community that, or in a household that just doesn't have technology easily available. And so we advocated for having 211 be a partner where people can call a well-established and trusted number and let us do the legwork of getting people registered in the system so that technology is not a barrier to a life-saving resource. And so those are some of the ways, in addition to the ensuring access to adequate and timely healthcare interventions and access to the vaccines, that we were trying to mitigate some of the disparities that we were experiencing as a society.
Those observations were pretty common. I mean, we saw states, initially trying approaches like starting, drive-through testing sites, only to realize that much of the communities that they needed to get tests to didn't have cars, or places having numbers for people to call. And one of the first questions that you get asked is if you have insurance and what your policy is, and that's a proxy question for citizenship. So, recognizing early some of those things, and, I can imagine that those are lessons that we absolutely need to carry forward because they're going to keep coming up in future events. Would you agree?
Absolutely. I think we've done a lot of prep work to establish culturally and linguistically accessible standards. And there are a lot of things that we are proactively working on through health equity zones in Rhode Island and similar initiatives in other parts of the country where we have place-based initiatives that are bringing communities together, community-based organizations, health systems, government together to work on health disparities. And we need to leverage those relationships, those infrastructures, those partnerships to deliver timely information, timely resources, and to be the heirs to the ground to make sure that we're meeting the needs of our most vulnerable neighbors.
I'd like to stay on this equity theme, maybe turn to you, Adam. And we started off talking about vaccines and the remarkable achievement, and then we talked about some of the disparities we saw and the kind of operational importance, strategic importance, as well as the moral importance of having an equitable response. But we also know that having vaccines didn't automatically translate to vaccinations, both here in the US, but certainly globally. So maybe just in your role, particularly thinking about these issues, but also your global work, can you reflect a little bit on vaccines and equity? And then also maybe if you could give us a sense of sort of the global picture of COVID and what some of the impacts were. There had been, I remember, an early narrative that, well, if you looked at the dashboards, it made the rich countries look like they had been hit the worst, and it made the poorer countries look like they had been spared. And that was clearly a misperception, but I'm curious sort of your thoughts on that and if that had a role in terms of making decisions about who got vaccines and when.
Yeah. So when I had my daughter and she was an infant, somebody gave me some advice, which was all babies sleep through the night if only you turn off the monitor. And there's this amazing thing. If you have 0 COVID tests in your country, then you have 0 COVID cases and also 0 COVID deaths, which was exactly what happened and played out across most of the global South. They had no access to the COVID testing, which was even hard for us to come by. If you remember, early in the COVID pandemic, even at Rhode Island Hospital, we were rationing tests, and I wasn't allowed to do tests on every patient I wanted to. But during the entire pandemic, much of sub-Saharan Africa and South Asia and parts of Latin America and the Caribbean had no access to testing. And so if you look at the numbers that were reported to WHO in the first 2 years of the pandemic, supposedly 6 million people died of COVID. But the Global Burden of Disease Group at University of Washington did a modeling study where they looked at excess mortality, how many more people died in 2020 and 2021 than we would have otherwise expected. and they found 18 million excess deaths worldwide. And in some places like the United States, the number of reported COVID deaths were just slightly below the number of excess deaths. But in places like sub-Saharan Africa, the number of excess deaths were 14 times higher than the number of reported COVID deaths. Many, hundreds of thousands or millions of people died in the global south from COVID that was never recognized. And that by itself is a huge inequity, because if you don't think there's a problem there, you can't respond to it. So they weren't prioritized as much for vaccines, they weren't prioritized for resources, for a variety of reasons, but partly because of this misconception that they weren't affected by it. I will also say that from an inequity standpoint, one of the other pieces of inequity is actually the fact that the response to COVID that we initiated in the global north became sort of the standard of care for responding to COVID everywhere in the world. It is very questionable, as I'm sure we'll get into, how much of our response to COVID-19 in the global north, such as shutting down the economy and shutting down schools, was actually a good idea here. But unquestionably, it was a horrible idea in much of the global south, where there wasn't government funding that could actually keep people afloat, where nobody had jobs where they could work from home. And it ended up actually, part of that excess mortality may not have been just from COVID, it may have been from the negative effects of things like lockdowns, which led to many people not being able to eat and their children starving because they couldn't go out and earn their money that they needed. So I think it's important for us to think about both inequities that happen from the point of view of the virus and the lack of resources, but also inequities that happen when we force or push solutions that are not context appropriate on places. Yeah. And then the second piece of your question around vaccines, I think, is a really important one, because as we heard, it was a miracle to develop these incredible new vaccines in such a short period of time. But it wasn't a free miracle. We spent billions of dollars on it. The US government in particular spent billions and billions of dollars that made it possible. And we can question whether that would happen again in the future. But one thing we didn't spend billions and billions of dollars on was actually educating people about these vaccines and convincing people that these were actually going to protect them, to not harm them, and using trusted communicators and mediators to deliver that message. Often I think people in our world divide the United States into the 2/3 of people who got vaccinated, who were sane and reasonable, and the 1/3 of people who didn't get vaccinated, saying, well, they're just crazy and have horrible ideas or the wrong values. But in fact, the world is not that black and white. We did a big study, and I didn't do research on this in the US, but we did a big study in the Democratic Republic of Congo on vaccine hesitancy. Originally, it was designed to look at vaccine hesitancy around the Ebola vaccine that had been rolled out for the first time in Congo in 2019 during the Ebola epidemic there. But then when the COVID pandemic hit, we added on COVID questions to the vaccine hesitancy survey. And what we found was that most humans were, conflicted. They weren't all in one camp or another. The vast majority of people that we surveyed believed in vaccines. They believed in Ebola and COVID being real. They believed that the vaccines could help them. And the vast majority also believed that the vaccines had side effects, that they were concerned about the effects those vaccines might have on them down the road. They were concerned about where the vaccines were made and what the ulterior motives were of people pushing the vaccines. And many of those people who were worried about the vaccine still got vaccinated. And some of the people who did believe in the vaccine didn't get vaccinated because of this balance. And I think that was true probably everywhere in the world. One thing we learned during the Ebola outbreak in DR Congo and prior Ebola outbreaks that I worked in was that we need to use trusted messengers. And when we asked in the survey who people trusted, it was very much their physicians, their health workers, it was their family, and it was their religious leaders. To a large extent, it was traditional media sources, actually much more, this is Congo, but much more than sort of social media. And we needed to do a better job here in the US and in many countries in the world of using those trusted mediators to educate people about COVID and vaccines. I'm not sure why somebody thought it was a good idea to just put Anthony Fauci in front of the entire country and tell everyone to get vaccinated and thought that that was going to work as a one-size-fits-all approach. We needed a much more nuanced approach where we had country music singers talking to their base about COVID vaccination, where we needed pastors and imams talking to their congregations. We needed a much more nuanced approach for it.
You brought up the kind of role of politics, and maybe turn to you, Scott, because you're sort of ground zero politics. You were in a position reporting to politicians. So can you talk a little bit about the role of politics in the response to COVID? And then also, because we want to have this forward looking, we're clearly at a profound moment right now. And just what your thoughts are on where we are in that profound political moment.
Yeah, no, thank you. Really important question. So if you look over the first 18 months of the pandemic, your biggest risk factor for dying was age. This is a virus that heaped its fury on people who were older. But once you got past 18 months, your biggest risk factor for dying was who you voted for, whether you voted for President Biden or President Trump. And, David Leonhardt in the New York Times coined this phrase, red COVID. And when you got to the second part of the pandemic, really, that was the biggest discriminator, who you voted for, not whether you are older. So the question is, how does this come about? And, I think pandemics, if you look at other pandemics, they really are a mirror of society. And, initially, when there's a tornado, fires in California, communities come together. But that only lasts so long. So for the past 3 to 4 decades, our society has become increasingly polarized, Republican, Democrat, college educated, non-college educated. We have this really vast chasm in our country right now. And in terms of politics, it's, one of the misconceptions is that red states and blue states did things differently. Over the first year of the pandemic, they didn't. Red states, blue states, they had lockdowns or safer in place. They closed their schools initially. They widely promoted vaccines and vaccinations. And then we started seeing a shift really that started happening in March and April of 2021 after the election of President Biden, where you really saw this big divide between what red states did and what blue states did almost in unison. And we got to the situation where, blue states would promote vaccinations, would promote mask mandates, would have schools closed. Red states, starting in March 2021, all across the country, red state governors stopped promoting the vaccine. And then, anti-mandates, kids going back to school. And so, we're really in the polarization has become amplified. Culture wars. The pandemic became a foot on the gas for culture wars. And this last election, I can submit that COVID was the reason behind how things changed. Society became even more and more polarized. So going forward, it's going to take a lot of work. We can talk about, we have to communicate with people who are in rural America, communicate with individuals who haven't gone to college. It's more than that. Politics is all about personalities and politicians, and it's really going to take political will to actually say, can we get together? I mean, you hosted this incredible summit about a year and a half ago about pandemics in democracy, where you had people from red states, blue states at different kinds of levels. I remember early on the pandemic when I saw the split proposing, let's get 3 red state governors together, 3 blue states governors together, put them in a room, and let's come to some kind of common agreement. How do we keep schools open? How do we keep our economy open? And I could not find an appetite for that because it became a political weapon. And this is the situation where we are now, where it's even become more extreme. We've degraded the expert. Now we're degrading, institutions of science and institutions of public health. So I think it really is going to take, almost a cultural revolution where we can actually try to get both sides to the same table and say, for the good of the populace, we did not have to have 1.1 million deaths. We don't have to have anybody dying for COVID right now. But where is the will to do this and make it for the greater good rather than for politics?
Do you think, the question is, you said there was low appetite because it was seen as a political weapon, so clearly there was some calculated political benefits to weaponizing it. Do you think that there will be, it's able to remove that incentive, or that we're going to be able to overcome that? Just looking forward, can we get out of this cycle of just you versus us?
Yeah, you versus us. It's a really important question. You being individual freedom and us versus the benefit of society. And we're seeing this real shift about half the country into the you rather than the us. Whether it's fluoride in water, that's becoming another litmus test. People should have the choice to drink fluorinated water or not. And then the consequences of taking it out are, children with rotting teeth. Healthcare. It's up to you to control your own personal health versus society providing guidance in terms of keeping water safe, the environment safe, access to health care. So, this is one of these real battles that we really are seeing now. During the pandemic, there was this different kinds of perceptions came up where it's better to get COVID and get natural immunity than to get vaccinated. You had a choice to get vaccinated or not, but whereas very clear that of all the measures we put in place, and it's remarkable to have a vaccine in such a short period of time, but people said, it's my choice to get vaccinated versus not. And part of this came when you have mandates for masks, mandates for vaccines. There's clearly a boomerang effect, and I saw this in Florida. And so, we're a country of individuals going all the way back to Tocqueville. Other people have written about this in the 1800s. And it's an extension of that in understanding that American mindset.
I'm struck by how much we keep asking the wrong questions and we keep trying to reduce it to these binary choices. And a reporter was recently asking me, called to say, tell me about the evidence. Did lockdowns work or not? And I said, that is the wrong question. That's the wrong question. Obviously, if you kept every person on the planet inside their house for 2 weeks, truly kept everybody on the planet inside their house for 2 weeks, such that they had no probability of encountering another person, so that if they happened to be incubating the virus, they wouldn't pass it on, we would have stopped the virus. But there was no circumstances in which that would practically happen. So the question is, are the measures appropriate given the disease control goals and compared to the other impacts that they could have? Are they aligned with the values of the community? Is it the right approach for the communities? Are there alternatives? And one of the things that we saw when we talked to communities on this topic of COVID and democracy was that a lot of places just rejected, they said, what, mask mandates may not work in our communities, but we think masks work. So we're gonna just make masks accessible. We're gonna make them available. We're gonna talk about what their benefits are. We're gonna remove the barriers to using them for people. And anyway, so I'm struck by still 5 years later, we have so much of the conversation framed around some of these wrong questions. I would love to give folks an opportunity to ask questions, and I don't know how we're going to do that, if there's a microphone or people are going to stand up. So I don't want to hog the conversation. I have a million more questions for these folks, and I'm happy to keep going, but if others want to chime in with questions, please do sort of raise your hand. Maybe I'll just keep going until folks feel brave enough to stand up.
If I can comment on that point you made, that's such an important point. I think one of the great divides that happened, going into, March, April, May of 2020, when we had the lockdowns, is that first, we didn't really know how do you keep society going. You've written about this. Lockdown should be relatively short term. How do we get kids back to school? How do we keep the economy going? And I saw this firsthand. You started having lockdowns, 22% unemployment in this country, businesses losing revenue, and they would then go to elected officials. You're killing us, and so, and then if schools are closed, parents can't work, it has an effect on the economy. So I think, one of the major lessons really is with the next pandemics, how do we protect society to allow society to function even though it's at a lower level? How do we keep economy going? How do we keep schools going? And I think if we can bridge that divide, that sort of helps take the economic part of this out of the equation.
Yeah.
Yeah, if I can add to that, the concept of equity is one where you can't take one size fits all approach to anything, whether it's an intervention or education. And we do need to understand that there's different realities that different communities, urban, suburban, rural, red, blue, purple, are navigating. And so amongst the science-based options that we have, what can we start with that will be effective given the reality of the circumstances that we're dealing with?
Yeah. And inherent in that is that there's a question that's asked. And when you were talking about sort of working with communities, part of it was involving communities in the conversation about what can be done and what works given the needs and circumstances of the communities, which is not necessarily something that could be defined at the national or global level. It has to be sort of a bottom-up, I think, approach. Yeah.
When in 2014 and 2015, similar to Craig, I was working in Liberia, Sierra Leone, Guinea as part of the Ebola response. And during that response, there was actually an anthropological platform of anthropologists who were going out, talking with communities, trying to understand what the perspective of those communities were on the different Ebola response measures and finding what worked, and then posting those on a platform so that they were available for all the humanitarian and Ministry of Health responders who were working. And the investment that went into trying to understand the community perspective is something that is natural and something that we often do in humanitarian work in other countries, but we for some reason don't do in our own country. And that I find surprising.
So not availing ourselves of global health best practices as though human beings are somehow different. One of my favorite quotes, just generally in public health, comes from the Ebola West Africa experience from Dr. Tolbert Nyanzwa from Liberia, who said quite clearly, if you don't have the community on your side, you don't have a public health intervention. And that, applying that to the US COVID experience is really quite a profound statement because of the fact that that piece, making sure the community was on our side, was, not, in some places, an afterthought, for sure. I did see some hands raised, so we'll start with the questions.
Hello, thank you so much for everything today. And just to go back to just the topic and the title of this engagement today, I have realized this isn't a yes or no or black or white answer, but are we ready if H5N1 is to get bigger, and are we ready? Does anyone have any?
Does anybody think yes?
So, I will just take a nuanced approach to that. Firstly, I think one thing you have to clarify is, are you talking about the US or the world? Because those are very different answers. And even for the world, it's going to vary based on different places. That being said, I think that there's no question we learned a lot of lessons from the COVID-19 pandemic, as we have from many other epidemics and pandemics before it. The question, though, is can we implement those lessons? And we know in all sorts of facets of public health, there's a no-do gap. There are so many things we know. We know that smoking kills, but are we able to actually get people to stop smoking? That is one of the important questions. And so much of what we learned, yes, we learned how to make a vaccine in 10 months for a new disease that had never been seen before. And we did that with tens of billions of dollars in government investment. So will we be able to do that again is a real question. It's not certain that we'll be able to produce a new vaccine to H1N1 in the same sort of time frame if there isn't that type of investment there. We also, learn many lessons about what works and what doesn't work in different communities with regards to public health interventions. But the question then remains, are those communities going to have the resources and are they going to be prepared to implement those interventions in the future? I would say that at this point, I wouldn't give that a huge, high likelihood in the United States. I think in other countries, there will be a lot more application of the measures they learned, and perhaps they will do a better job of managing the next pandemic than we did. Maybe even some low and middle income countries will do a better job than us because they'll be able to apply some of the lessons they learned for their own context.
I think as someone on the research side, this conversation is, sobering because I'm actually, this semester, I'm teaching in the School of Engineering and Immunoengineering class. And actually what we did last week was pull up the sequence of H5N1 flu. And I said, design an mRNA vaccine. And so within the time frame of a 50-minute class, we could go on the NCBI website and we could pull up the genetic code for what is published right now of this flu vaccine. And then by the end of the class, we had an mRNA sequence that with the information we have now, we think this would work. We think this would be an effective vaccine against the flu. And so I think we also have infrastructure, right? We've learned a lot. FDA has learned a lot about how to manufacture and regulate. So hopefully the investment would not be as great for the next pandemic, but it's a sobering conversation.
For the future.
Yes, absolutely.
Yeah.
If I can answer that question, to quote myself in USA Today yesterday, I think the answer to that question is resounding no. We hear about the incredible things that Teresa's doing. Jen talked about wastewater testing, surveillance, home testing, and things like that. But we are even more polarized now than we were at the start of our first case of COVID-19 in the United States. Data drives the narrative. Experts drive the response. But look at what's happening now. During the pandemic, we just had maps of red, blue COVID. We didn't have maps of red state, blue state measles. And that's where we are moving into a situation where society is even more polarized than before, where we don't trust the expert, where we're talking about treatments that are not proven, that will be followed by a large portion of individuals in this country. So it gets back to the clarion call, which I talked about before, which I know Jen is focused on, pandemics in democracy, is at least for public health, can we put away our political differences to be able to come to some kind of common ground, to have a dialogue about what it is going to take? Because I'm very fearful about what we're going to start seeing with measles, pertussis, polio, other diseases. We never were separated before by state borders, but now, this is going to be the harbinger of what we can potentially see.
What do you think, Larry? Do you agree?
I do. I think, unfortunately, we're in a better place, I think, science-wise, infrastructure-wise. We've learned a lot from COVID-19, but we're still challenged with misinformation, disinformation. And I'm also teaching this semester a course on race, racism, and health, and the multiple levels of racism. And we still struggle with systemic racism in addition to interpersonal racism. And those are the things that are going to challenge our response to whatever health challenge we're facing next, and the vulnerability of different communities. So unfortunately, I think if you add all of the variables together, I don't think we're ready.
I agree with you all. I think, though, I will say that some of where we are is partially fueled by the luxury of amnesia, and that were we to be in another event, the hope is that we can do things before the next event so that we don't have them upend our lives and lose another 1 million Americans and tens of millions of people globally. But that said, if we had another fast-moving pandemic that is at the same or worse lethality, I think it would be a fundamentally different situation. I think just even seeing what's happening with measles, right? They're going now and offering measles vaccines, and people are taking it. Not everybody, but people are taking it. These were people who didn't take it before. I've gotten more calls from random people asking about measles today than I did in 2019 when we were at risk of losing our measles elimination status. So I do think that when people see what's happening and it becomes real for themselves and their families, I refuse to believe that people don't want to protect themselves and their families and that they will go seeking information. Now, will they listen to the CDC? Remains to be seen. I think it has to be a bottom-up approach, but I do think that it will be a fundamentally different thing. I can't imagine a scenario in which people will say, there's this high lethality, fast-moving event, and we don't want a vaccine.
Yeah.
Not everybody will take it, but more people would than might today.
I think the best example for that is, only 2/3 of Americans got vaccinated for COVID, but 95% of people over 65 in America got vaccinated for COVID. That means across red states, blue states, everyone who knew that they were at risk of death got vaccinated. And so, I think that a lot of it too is changing the incentives for individuals. Like in most places, mandates aren't necessarily going to work, but that doesn't mean that you can't do anything, right? So what about economic incentives? I calculated that it would have cost less money for the government to give a $50 CVS gift card to every American who got vaccinated than it did to actually create the vaccine. And probably lots of people would have gotten vaccinated for a $50 CVS card who would not have gotten vaccinated otherwise, because you just change the economic incentives for them a little bit. I also, on the point of misinformation, I've been at so many panels over the last 5 years on misinformation. At conferences, everyone wants to talk about misinformation and disinformation. But I want to turn on its head. Misinformation, disinformation is not something new. In the Ebola epidemic in West Africa, there was a strong belief that the Ebola treatment centers were being set up by European NGOs to harvest organs of Africans and ship them back. And why did people believe that? Because they saw their loved ones go into the Ebola treatment center. When they died, their bodies were burned. Nobody came out. And so they said, what are they doing? They must be shipping the organs to Europe. How did we combat that in our Ebola treatment center? We put outlets in every single room. How does that solve the problem? That means that the patients could charge their cell phones and they could talk to their family every day and tell them about the care they were receiving, and their family could know that they were receiving good care in the Ebola treatment center and not having their organs harvested. This is a creative way to communicate, and we need to think about what are creative ways that we can communicate before and during the next pandemic to reach people. And I promise you it's not going to be a post on X. No matter how brilliant your post on X is, that is not going to reach people, because it's just going to be drowned out by a million other negative posts.
Yeah.
It's going to be something else, like installing outlets in a Ebola treatment center patient room. Not exactly that, of course, but something like that that's going to allow you to communicate and get the message through.
Did I see a question over here? There was another hand that was up. Okay, good.
Hi, thank you all for your insights today. I wanted to ask about, we touched on there being a very different experience in low and middle income countries versus high income countries. So I wanted to ask about the recovery from COVID-19, like the economic recovery, for example, as well as the lessons we've learned and how they were different for low and middle income countries versus high income countries.
Anybody have thoughts on that?
So I'm not an economist, but again, I do know that, the negative consequences of things like lockdowns, for instance, were much more severe when they were implemented in low and middle income countries than they were here in the US. Here in the US, yes, we reached 22% unemployment, but the US government made sure that businesses were funded so they didn't go under. Everybody got a check in the mail from the US government multiple times. Nobody, as far as I know, maybe I'm wrong actually, but not many people starved to death in the US because of lockdowns. In other countries, people literally starve to death because of lockdowns. And so the economic impact is not just unemployment rates, it's actually people's children dying. And so we need to think a lot more when it comes to interventions in other places around how we make them contextually appropriate. And we weigh the risks and benefits, as was said, between an intervention that might be incredibly effective, but like, going back to your thought experiment, if we had every human on the planet, self-isolate in their house for 14 days, then we would have ended the COVID pandemic in 14 days, but 90% of the population would have died of starvation, right? So
Exactly.
got to weigh the risks and benefits there.
I think locally we benefited, building on your point, Adam, I think we benefited from having a pretty robust nonprofit sector locally and across the country, where we were able to be responsive to the social needs of households and communities while they were weathering the lockdown and while we were trying to figure out how to safely reopen the economy and balance that healthy tension between public health and the local, microeconomics and macroeconomics. And so we made out okay. In other settings where there's not that type of infrastructure, I think that looks a lot different, to Adam's point. And I think now as nonprofit organizations, which both at the national level and local level, governments rely on the nonprofit sector to carry out their mission. If we see the nonprofit sector start to implode because of the decimation of funding or because of executive orders or because of an ecosystem, an environment that's not supportive to healthy and thriving nonprofit organizations, where do we have the capacity to support communities? Because the government can only do so much. And even as we see the shrinking of government agencies, who then is going to support the community? So I think it does force us to ask some critical questions in our readiness to support both the economic impacts of a pandemic and the health impacts of a pandemic. What infrastructure will be there to support us?
And maybe just to broaden it beyond just the idea of recovery and the kind of like, did people have a salary, but just looking at the role of sort of social, first of all, pandemics are not just health events. They are health events in the sense that they touch all of health. So it's not just about the individuals who contract a particular pathogen and get sick or die with that pathogen. It's the impact they have on all of health, the interrupted services, the comorbidity. It's a health-wide event, but it's also a society-wide event. And so thinking about those social dimensions, first of all, what would enable people to follow public health advice, the social dimensions of that, but also what are the social dimensions of the interventions? And what are the resources that are needed to support and enable a response that is not ignorant of those social dimensions, that addresses the needs? Like, sure, if you decide that the role is to keep people in their houses for 14 days, what do you need to provide to people to enable them to do that, to remove their barriers? Because we talked about equity before, and not all of us can do that as well as others. And so thinking of these events as sort of a society-wide rather than a public health versus economy, which is what you brought up. Anyway, so I think that piece is one of those areas that I would kind of flag for us as something we need to focus on for going forward. Any other questions? Yep.
Hi, thank you all so much. My question is, if you think the success of implementation and interventions in general does fall along political lines or is kind of solely centered around politics, what is your advice for the next generation of people and or students graduating and entering the public health workforce for how their work can be successful?
During the pandemic, the 50 state health officers, we would have calls every Tuesday for an hour and every Friday for an hour. And the person who was the state health officer from one of the middle of the country states got on the call. He was very heated. He said he had just had a conversation with the superintendents of all the schools in the state. He said, it's your fault, because you are not teaching your students to respect authority, to respect the expert, to respect science. And we can talk about misinformation, disinformation. I think we have to talk about who information. How do we get people to trust? experts like folks who are here on this panel. So I think it really has to start something really on with basic education, in this country to, why should somebody, why do we see, Tony Fauci, other people continuously attacked and degraded by individuals who don't have a background in science? Like it or not, in terms of, Make America Healthy Again, has a huge following. Why is that? Why people are looking at alternative treatments? Why do some people believe that vitamin A is the way that you treat yourself with measles? Because of the WHO information. So I think really happens at all levels, where we really have to be able to focus on respect for experts, respect for the learned individual, and respect for science. And it's a really tough issue to grapple with, especially as we're talking about changing educational standards all across this country. So that's why, for all of us who are here, all of you who are here, getting back to, instead of misinformation, but who information, how do we continue to reach those individuals that people are listening to that we don't listen to? And that's really, really important.
Can I maybe push back on that just a little bit, or
Sure.
maybe add some context, which is that I wonder if it's about a lack of respect. I mean, because I think respect is earned, right? I mean, you can teach people that this is what the educational trajectory is, and this is what kind of knowledge one amasses through the trajectory. But if you're not showing up in people's lives in a way that matters to them, I think it's hard for whatever that is to overcome that. And I was profoundly affected in COVID in talking to people, and I talked to hundreds of people of all different stripes. And one of the things I would hear very often from people who were, asking questions about COVID or vaccines was that they kind of felt like they didn't know who to trust. And I did the thing that we got taught to do in public health that I now no longer do. I did it for a while in the beginning, was like, well, do you think you could talk to your healthcare provider? Because I thought that's the expert that people are most likely to be able to access. And I've stopped saying that because I kept hearing over and over again from people, I don't have one. So they don't have one. Who are they supposed to talk to? And I remember when the vaccine first became approved for kids, getting an email blast from my kid's pediatrician's office, one of the largest in the state that I was living in at the time, that said, do not call us. We do not have the ability to answer your question about these vaccines. And I thought, well, if parents can't talk to their kids' pediatricians about vaccines, where are they going to go? They're going to go to the internet. I mean, there is no other place to go. So I do think we have to create an infrastructure to bring that factual knowledge to people and to earn their trust over time, because we have showed up in a relevant way for people in people's lives.
Yeah, I would add to that. I think your comment is spot on, that trust is earned. And I think the best thing that we can do as a society is to establish trust with trusted partners who then downstream can be the ones that are brokering information and relationships to individuals and communities. And for emerging public health practitioners, get involved, and whether it's with an organization or an initiative that's a passion of yours or that you're curious about, in addition to your public health knowledge, you may be the difference between people or a community trusting or having access to trusted information, because not everyone's going to have a primary care provider. Not everyone's going to find their way to a trusted and reliable source of information, but you or the organization or initiative that you're connected to could be the difference maker. And so that's something at a community level we can work on together. I think government has the responsibility to be proactive in forging those relationships as well, in addition to making sure that we're advancing science.
Question over there.
I think that's our last question because we're at time, but we'll take a quick one. Yep.
I don't know how quick this is going to be. Panel, do you think it would be wise for you all as a group to consider that maybe anti-intellectualism may be a factor too, as well, as far as this predicament? Because I'm looking here on my smartphone, and this is the contradiction. Schooling is available to many people in this country, but look at this one particular stat, or three. 21% of adults in the U.S. are illiterate, and this is 2024. And of the adults that are literate, 54% of adults have a literacy level below 6th grade. and another 20% are below the 5th grade. When I was in public health in Rhode Island, it was a major concern that I shared with the Department of Health in terms of reading levels. Folk cannot read much of their literature. But this is a very delicate matter because how might someone feel when you can read it in terms of comprehension and they can't, which gets back to trust. But I think it's a little bit more complicated. But I think anti-intellectualism has a lot to say in terms of the predicament that we're in.
Yeah, it's an interesting observation, and I would say to that, the trusted connection, or the connection to trusted sources, trusted partners, trusted community leaders as brokers of information beyond printed literature or beyond what's available online, can be the difference maker. I know we're short on time, so I'll end with one quick analogy. One of the campaigns that was implemented was with people from diverse backgrounds across Rhode Island, Asian Americans, Latino American, African American, places that might connect with different audiences. People who were willing to or had gotten the vaccine and talking about how do you find out more. It was like a 30-second spot. How do you find out more about the vaccine? Go to C19vaccineri.org or something close to that. I got a message on Facebook Messenger from someone who I hadn't talked to in years, and they saw that 30-second spot, and they said, hey, my partner is saying don't get the vaccine, but I saw your video. Should I get the vaccine? And I said, absolutely. It's the best thing that we have to protect your risk of hospitalization or death. We can't do that times a million, but the organizations, the community partners, those are going to be the ways that we reach people who can't access highly technical and inaccessible information. And so that's one way to address that.
So I think that's a great note to end on, because I think it really speaks to looking forward to the future, sort of bottom-up approach involving the trusted messengers, involving messages in a variety of different formats, recognizing that education is an important social determinant of health, showing up where people are, meeting them where they are, and I think part of it also is, to your question about how to get past it, is listening. And you were listening and talking. And I am grateful for you all. You are all my trusted messengers. And very grateful to you for the time today, but also just your continued leadership on these issues. We have a lot of work to do going forward. And I know that at this moment in time, particularly 5 years after the start of this really profound event that we would all rather forget, I think it'd be tempting to try to forget it all, and to not kind of walk into the future with those lessons, but also being willing to admit where we didn't get it right and trying new things. But I think the fact that we're having this conversation today, that we are kind of pushing ourselves to re-examine these issues, is just a sign of the larger commitment that I hope we all take with us. Everybody in this room has a role to play going forward, not just these esteemed folks up here who I know will continue to play important roles, but you all who are listening and internalizing these lessons and talking to your families and friends and your communities and all of the jobs that you have and will take in the future. So with that, thank you all. Thanks for the conversation and look forward to the chat and socialization afterwards.
Thank you.